Aloha, everybody. Welcome to Queen's free Speaking of Health lecture series. Tonight's lecture is called How to Fix a Broken Heart. I'm Mina Sugimoto from the Corporate Communications Department at the Queen's Health Systems, and on behalf of Queen's, I welcome you all this evening. I'm going to be introducing the doctors that we have today. Dr. Benjamin Plank is an interventional cardiologist at the Queen's Medical Center. Dr. Plank comes to us from Billings, Montana, where he built and maintained an advanced structural heart program. He graduated as a Doctor of Medicine from the University of Miami Miller School of Medicine in 2006. He completed his cardiovascular disease fellowship, followed by an advanced fellowship in interventional cardiology at the University of Rochester Medical Center in 2014. As a member of the Queen's Structural Heart and Interventional Cardiology programs, Dr. Plank provides the following services: structural heart interventions, TAVR, MitraClip, PFO, ASD closure, and valvuloplasty, coronary diagnostics and intervention via radio approach, and adult echocardiography. We also have a second speaker who is rushing over from a procedure. His name is Dr. Peter Tsai, cardiothoracic surgeon at the Queen's Medical Center. Dr. Tsai completed his undergraduate studies in marine biology and biochemistry, along with his master's degree in endocrinology at the University of California, Berkeley. He attended medical school at University of Southern California. After completion of his general surgery training at Los Angeles County and USC Medical Center and Kaiser Permanente Los Angeles, he went on to train in thoracic surgery at Baylor College of Medicine, Texas Heart Institute, where he stayed as tenured faculty, rising to the rank of Associate Professor of Surgery. He is currently a Professor of Surgery at the University of Hawaii and a Fellow of the American College of Surgeons, American College of Cardiology, and College of Chest Physicians. As a member of Queen's Heart's cardiothoracic surgery program, here are just a few of the things that Dr. Tsai specializes in: aortic repair and replacement, coronary artery bypass grafting, mitral aortic tricuspid valve replacement and repairs, thoracic endovascular aortic repair, and thoracotomy. So I'd like to first introduce Dr. Plank to the stage.
Thank you for that nice introduction. Hopefully you can all hear me. I apologize ahead of time. I'm recovering from a cold. So if at any point you can't hear me, just speak up and let me know, and I'll try to talk louder. But everyone can hear me okay? All right, good. So I have no disclosures. We're going to talk about transcatheter aortic valve replacement this evening. So this is a relatively new technology, new treatment for aortic valve disease, and I'll explain the procedure and the condition. So we'll very briefly review the anatomy of the heart. We'll focus on the aortic valve. We'll talk about aortic valve stenosis, which is the condition that this therapy treats. We'll talk about treatment options for aortic valve stenosis, including transcatheter aortic valve replacement and other options. We'll walk through a transcatheter aortic valve replacement procedure, or a TAVR procedure. And we'll also describe something called valve-in-valve procedure. So all of that will make sense, hopefully, by the end of the talk. So first, the anatomy. So very basic anatomy of the heart. The heart is actually a pretty simple structure. It's just a pump. And it pumps blood through the body. The heart has two sides. The right-hand side of the heart receives blood from the body. Blood coming back from all the organs and the tissues after the blood has delivered the oxygen. So by the time the blood reaches the heart, coming back from all the organs and tissues, the oxygen has been used up, and that blood has to return to the heart to be pumped to the lungs. So the right-hand side of the heart receives that blood and then pumps that blood to the lungs. The blood becomes saturated with oxygen in the lungs and then delivers that blood that is filled up with oxygen back to the left-hand side of the heart, and the left-hand side of the heart pumps the blood to the body. So if you took the heart, which is a pump, and you Sliced it down the middle, you would see that the heart has valves. In order to keep blood moving in one direction, the heart needs to have valves. There are actually 4 valves in the heart. We're going to talk about the aortic valve tonight. The aortic valve is circled here. If you looked at an aortic valve, you would see that a normal aortic valve has 3 leaflets. Leaflets are the things in the valve that open and close. Blood has to be able to move one direction through the valve, but not move backwards, and that's what the leaflets do. They allow blood to move easily through the valve in one direction, and then the leaflets will close so the blood doesn't move backwards. So this is what it looks like when the valve is closed. This is what it should look like when the valve is open. Aortic valve stenosis is a condition where the leaflets become thickened over time. This can happen for a number of reasons, and it can happen to anybody. But over time, the leaflets may become thick and they become stiff. It's difficult for the leaflets to open all the way, so instead of opening up nicely like this normal valve, the valve may only be able to open a little bit, like this abnormal valve, this thickened valve. And also sometimes the valve can't close all the way because the leaflets are rough and they don't close tightly together. So you might have a leak as well as difficulty opening the valve. But the condition aortic valve stenosis refers to a problem with the leaflets opening. So this is a problem. If the leaflets don't open all the way, the heart has a hard time pushing that blood forward through the valve. And that can cause lots of symptoms and lots of difficulties for someone that has that condition. So aortic valve stenosis, that's the name of that condition. So a few quick facts about aortic valve stenosis. It's pretty common. It tends to affect people as we get older. If you take everybody 75 years of age or older, approximately 2.5 million of them will have this condition. That's over 10% of the population. It's more common in men than in women, but I'll tell you that that fact breaks down the older we get. So when people are in their mid-80s, I see just as many women as men with this condition in my clinic. Aortic valve stenosis always starts out gradually, so it'll be very mild at first. You won't even know you have it, but over time it will gradually but very slowly get worse, and we'll talk about that in just a moment. And there really are, of all the causes, you can break them down into 4 categories, or 4 main causes of aortic valve stenosis. Again, aortic valve stenosis, where the leaflets of the aortic valve become stiff, it has a very hard time opening, and this causes stress on the heart. So 4 main causes of aortic valve stenosis. One cause is calcific aortic valve stenosis. So what that means is the leaflets become calcified. Calcium is a mineral. Calcium is in our food that we eat. It's in our body tissues. And calcium can actually build up in the tissues in our body. That includes the aortic valve. So the leaflets can become calcified. If you look at this leaflet, this is an aortic valve that a surgeon took out to replace. You can see here there are 3 leaflets. Here's 1, 2, 3. You see my cursor? These yellow clumps, these are the calcium deposits. So these are weighing down those leaflets so that they don't open very easily. So that's called calcific aortic valve stenosis. Some people have birth defects affecting their valves. So some people are born with valves that are abnormal or not typical. This is actually the most common birth defect affecting aortic valves. Notice that this valve has 3 leaflets. A normal valve will have 3 leaflets. This is a valve that only has 2 leaflets. And you can see on this valve there are some deposits of calcium. So this valve has become thickened over time, in part because it only has 2 leaflets. When a valve only has 2 leaflets, we call that a bicuspid valve. And the fact that there are 2 leaflets mean that the blood as it travels through that valve has more turbulence. In other words, it doesn't move as easily through that valve over time, and the valve wears down quicker than a valve that has 3 leaflets. So people that have this condition, a bicuspid aortic valve or a valve that has 2 leaflets, may have aortic valve stenosis sooner than somebody that has a calcific aortic valve stenosis, that has a normal valve structure. Rheumatic fever. So rheumatic fever is relatively uncommon on the mainland, but in other parts of the world, rheumatic fever is very common. And rheumatic valve disease is very common in other parts of the world, and it's relatively common here in Hawaii. There's a big mix of people from all over the world here. So we see this more frequently here than in other parts of the country. Rheumatic fever is a condition caused by, really by a strep throat. So a kid might get strep throat, have a sore throat, not get treatment, not get antibiotic treatment, and over time, what can happen is the body, as it's reacting to the strep infection, will cause some inflammation in other tissues. And that inflammation can go on over time, and it can affect different parts of the heart, including the valves. So what you see here in this picture is a valve that's been affected by rheumatic fever. This was a normal valve. It had 3 leaflets, but those leaflets have become thick and they're stuck together. I don't know if you can see that, but they're stuck together. So this valve has a difficult time opening all the way. This is rheumatic valve disease caused by rheumatic fever. Another cause, radiation therapy. So some people have had to have radiation therapy to their chest for different types of cancer. Radiation therapy treats the cancer, but it can also affect the other tissues in the chest, including the heart. So that can affect the heart valves, can cause the valve leaflets to thicken, and can lead to aortic valve stenosis. If you look at these 4 categories of causes of aortic valve stenosis, certainly the most common one is calcific aortic valve disease, the one that tends to happen as we get older. Birth defects is less common. Rheumatic fever in this country is less common. Radiation-induced valve disease is fairly uncommon. So if somebody has aortic valve stenosis, if that valve disease gets worse to the point where it's causing stress on the heart, people will develop symptoms. Probably the most common symptom of aortic valve stenosis is feeling out of breath. So maybe doing activities that you're used to doing, like walking or maybe going up your stairs at home, things that you could normally do with no difficulty becomes more difficult. And you may have to stop and rest and catch your breath because when you do these things, you feel out of breath. Sometimes people have some discomfort in their chest. Maybe their chest hurts when they're doing these same activities, walking, going upstairs, lifting grocery bags. Physically exerting yourself may cause some chest discomfort. You may not be able to exercise much because of these things. And sometimes I see people in the clinic and they don't really complain of feeling out of breath and they don't really complain of having chest discomfort, but they tell me that they really don't do anything. And when I really ask them, well, why aren't you doing anything? They realize, well, it's because if I did, I would feel out of breath or I would feel uncomfortable. So exercise intolerance or not being able to exercise as much as you used to is a symptom of progression of your aortic valve disease. Sometimes people feel dizzy or they may even lose consciousness. So maybe you're sitting down and when you stand up, suddenly you feel lightheaded. Or maybe you're walking and you feel lightheaded or even passed out. That's a symptom of aortic valve disease. The important thing to know is occasionally people will have severe aortic valve stenosis and they don't have any symptoms at all. And they're essentially asymptomatic. These people, when I see these people in the office, they have had a test that shows that their aortic valve is very tight, but they just feel good. They don't feel out of breath. They don't feel chest pain. No matter how many times I ask them, they feel great. These people I will watch very carefully and see them back frequently in the office because eventually, as that aortic valve gets worse over time, they're going to feel symptoms. It's just a matter of time. So physical exam, there are lots of different things that someone with aortic valve stenosis may have on their physical exam, something that their doctors may notice when they're examining them in the office. But certainly the most common thing is something called a heart murmur. So a heart murmur can happen for many different reasons or many different valve conditions. But a murmur is simply a sound that blood makes as it's traveling through an abnormal valve. So if your doctor tells you that you have a murmur, a heart murmur, that may be because there's an abnormality with your aortic valve. It could also mean there's an abnormality with another valve, but certainly could be a problem with the aortic valve. And over time, that murmur may get worse if it's due to an aortic valve problem. So natural history. Natural history is the phrase we use to describe what happens to a disease if left alone, if it just progressed on its own and it was not treated. So when you talk about aortic valve stenosis, the natural history of aortic valve stenosis, it will gradually, very slowly, but gradually get worse over time. So if you think about the valve opening, the valve should open to a certain size. That's about 3 square centimeters, 3 to 4 square centimeters. But over time, that valve will shrink. The leaflets don't open all the way. If you average it out, if you looked at it every year, it would shrink by about 1 square millimeter a year. And over time, 10 to 15 years, it's going to shrink enough to cause problems. Symptoms will usually start when somebody's in their 70s or 80s. So again, they may have this condition for years before that, maybe even decades, but it was mild and it wasn't bad enough to cause symptoms. So probably it was never even picked up. But by the time somebody's in their 70s and 80s, that's when it starts to become a problem for them, on average. And what we know about aortic valve stenosis is it not only limits how good somebody feels or quality of life, it limits how long someone lives. So this is now it's a classic paper from the 60s. There was this guy named Eugene Braunwald. He was or still is, a rock star in cardiology. He practices in Boston. But he looked at people that had aortic valve stenosis that died from it. And he looked at, I don't know how many charts, probably a couple thousand. And then he reviewed those charts and looked back over time. And it turned out that everybody that had aortic valve stenosis had that condition for a period of time and they had no symptoms. This graph looks at how long people lived with this condition. But once people develop symptoms, you can see that their survival drops off. So once symptoms start, the average life expectancy after somebody develops symptoms with this condition is about 3 years. So it really does limit how long somebody lives. This is if the condition is not treated. With treatment, people can live longer and feel better. So what are the treatment options for aortic valve stenosis? So one option is medications. Medications can help people feel better. If somebody has fluid retention, if they have too much fluid in their body because of the valve problem, the fluid may accumulate in their lungs or in their legs. We can give people medicine to help relieve that, to help get rid of the fluid. That's one example of a medicine that can help people feel better. But the medicines will not open up the valve, and it turns out that medicines won't help people live longer on average. So medicines are an option for everybody, but while they do help people feel better, they're not going to help people live longer. There's something called a balloon valvuloplasty. So this is a treatment in which we advance a balloon into the heart. You can see here's a balloon, and the balloon is inside the valve now, and we're stretching that valve out by blowing up the balloon. And then the balloon is removed. So that helps the valve open up better, and it reduces symptoms. It makes people feel better and can help. But it only helps for a period of time. What we know is after about 6 to 12 months, that valve will narrow down again. So this balloon treatment is a temporary fix, not a permanent fix. So heart surgeons can surgically replace a valve. This is a picture of a heart operation, and what you're seeing is the surgeon looking down at where the aortic valve was. The surgeon's already removed the bad valve, and he's suturing in or sewing in an artificial valve. So surgical aortic valve replacement is an option for a lot of people. This procedure has been done for many decades, and our heart surgeons are very, very good at doing this procedure. They can place a valve that's made out of metal, we call that a mechanical valve, or they can place a valve that's made out of animal tissue. For example, material taken from a cow or from a pig. And both types of valves have their benefits and their problems. But surgeons can implant that surgically. There are some issues with open heart surgery for valve replacement. The recovery is longer. So somebody that has their valve replaced surgically will have a scar on their chest, and there's pain associated with that healing process. It's manageable, but it's there. It's definitely noticeable. It can really slow people down for a period of time. And when people are older, when people are in their 80s or 90s, for example, they have a difficult time in some cases recovering from the operation. While the operation itself is not difficult for the surgeon, it's the recovery that can be hard for people. And now we have transcatheter aortic valve replacement, or I'll call it TAVR for short. This is a good option for a lot of people. We're able to implant a brand new valve in the heart without open heart surgery. And I'll explain how this is done. The recovery is easier than with open heart surgery. In fact, instead of spending 5 nights in the hospital after open heart surgery, most of the people that have this procedure done only spend 1 or sometimes 2 nights in the hospital before they go home. So transcatheter aortic valve replacement. So I'll talk to you about what this is. I always like to put it in context. I think the history is somewhat interesting. The first balloon valvuloplasty was done in 1985, so not that long ago. Remember, balloon valvuloplasty is what we just saw, where a balloon is placed in the valve and it stretches the valve, it opens the valve, and allows the valve to work better for a period of time. So the first time that was ever done was in 1985. It was done by a French cardiologist named Cribier. In 1992, there was a cardiology fellow, so a cardiologist in training. I believe he was in California. His name was Anderson. And coronary artery stents. I don't know if anybody has ever seen a coronary artery stent, but it's a little tube that's put into a blocked artery in the heart. And that was a new technology back in the early 90s. And this cardiology fellow, who was just becoming introduced to that technology, had this idea, well, if we can put these stents in arteries in the heart, why can't we just make a big stent and put a valve inside it and implant a valve in the heart? So he kind of had this idea back in 1992. And he actually went out and he bought his own materials and he put together this concept. He made this concept valve, which was his idea of what a stented heart valve would look like. That guy, Cribier, who did the first balloon valvuloplasty, found out about that and actually formed a company and tried to develop a more uniform stented valve. And you can see in 1999, with the company that he developed called PVT, he developed a stented heart valve, just like that cardiologist, that fellow developed, but certainly more robust. And you can see this is a photo of that valve that Cribier developed. So you have this big stent, this big round stent, and on the inside you have leaflets made from an animal. And then in 2002, Cribier, that French cardiologist, performed the first TAVR in a human being. And then shortly after that, the industry took over. The companies paid attention, and this company called Edwards Life Sciences bought out Cribier's company. I'm sure Cribier became a very wealthy person at that point. So this development in transcatheter aortic valve replacement kind of sparked these trials. So there were these big trials developed, funded by the companies making the valves, but they were actually very well put together and performed by independent investigators or researchers at pretty major institutions. The first landmark trial was published back in 2010. What this trial looked at was this procedure, transcatheter aortic valve replacement, or implanting a valve in the heart rather than open heart surgery. And they compared this technique to medicines alone. So again, this technique was not done in most patients, but they wanted to see how does it compare to medicines. And they only looked at people that were too sick to have an operation. And what they saw, if you look at this graph looks at death, how many people died over a course of 2 years. And again, these were the sickest of the sick people. These were people that could not have surgery. They were too sick to have an operation. 2 years later, after having the valve implanted, the risk of dying was significantly lower than if they were only treated with medications. So a major improvement in how long people live. People live longer with this valve implantation compared to medicines. They also felt better. So in 2011, they decided, well, the results look so good, let's compare this therapy to open heart surgery. And let's look at patients that are candidates that could have an operation, but the risk of a complication is very high if they had surgery. But they still are not sick enough to not have an operation. They could have an operation. So let's compare those people to getting the implanted valve. And you can see here that there was no difference in death after 2 years between the two groups. In other words, the implantable valve did just as good as open heart surgery for these patients who were at high risk of complications. Then in 2016, they looked at people that were even lower risk of a complication. So on the spectrum of people that needed to have open heart surgery to have a valve replaced, if you looked at what the risk of a complication was if they were to proceed with surgery, and we took the people that were kind of in the middle of that risk category and then compared them to the implantable valve, you can see that at 2 years, again, there was really no difference. People did just as well with the implantable valve as with open heart surgery. So based on these landmark trials, the FDA approved transcatheter aortic valve replacement for people who were too risky for an operation or who were very high risk for an operation, or also people who were medium risk for an operation. So those are the current FDA approval right now. Those are the people who can get an implanted valve rather than open heart surgery. And since 2012, if you look at hospitals that are performing this procedure, over time, it's gone up significantly. So with FDA approval of this therapy, there are many, many, many more hospitals that are performing this procedure. And if you look worldwide, back in 2012, there were about 4,600 transcatheter aortic valve replacements performed in the world. In 2016, there were almost 35,000. So there's many more of these being done worldwide now. And then if you compare the implantable valve, the transcatheter aortic valve replacement, to surgical aortic valve replacement, this red line is the transcatheter aortic valve replacement numbers over time. In 2015, there were more done than surgical aortic valve replacements in the world. So this therapy has really taken over, and in some places it's the standard of care. As more of these are being done and people are becoming more experienced, the risk of dying during valve implantation, which used to be a relatively high risk, back in 2012, almost 5%, the risk of dying during that procedure has gone down significantly. So over time, the technology has gotten better, and people who do the procedure are getting better and more experienced, which is exactly what you'd want to see and exactly what you would expect. So there are a couple of different types of heart valves that can be used. The way that these valves are implanted, we use catheters. Catheters are long tubes, and what we do is we use a needle. This is a groin. We use a needle to get into the artery in the groin, and this is where we put the catheter. So there are no incisions, no open heart surgery. We simply use a needle to get into the artery, and from that point, we put our tube, our catheter. So this is a video of a transcatheter aortic valve replacement procedure. This is the artificial valve, and it's at the tip of a catheter. We are seeing all of this live using X-ray. And we're going to advance this valve over this wire that we had already placed. This wire is in the heart. This is the aortic valve that we're replacing here. We're maneuvering this valve around the aorta, which is this big blood vessel in the chest. We're positioning the valve, we're getting the valve in place. And here we want to zoom in, we want to be sure that the valve is in perfect position. We're making fine adjustments to the valve, and then we're ready to deploy the valve. And there's a balloon on the inside of that valve that expands the valve. And the valve works instantly. And the catheter comes out, and the wire comes out, and that's it. And then we take the tube out, and the patient goes to the recovery room. And you can see that the artificial valve actually adheres itself into the old valve. So it actually uses the old valve to attach itself. And the force of that metal stent that the leaflets are attached to on the inside, the force of that stent allows that valve to stay there. It won't move. This is what it looks like on our X-ray machine. So this is the valve. We're blowing up the balloon. And we deflate the balloon, and the valve is done, deployed. So when we do a procedure like this, there's always risks. So to get the valve in place, we have to enter the blood vessel. So there's risk of bleeding because we're inside of a blood vessel. And there's always a possibility that we could injure the blood vessel. There's a risk of an injury to the heart that could require emergency surgery or could even lead to death. These risks are very small. On average, we're talking about a 1% risk of a major complication. But I think the risk that people fear the most is stroke. So when we implant these new valves inside the old valve, it can sometimes cause debris to break off of the old valves. Remember that calcium we were talking about? It's kind of like little stones, and they can break free from the old valve and travel through the bloodstream. And if they land in the brain, that can cause a stroke. Back in the old days, when the technology was just released, back in 2010, the risk of a stroke was about 5% at 1 month, and if you went out to a year, it went up to about 8%. Now in 2017, well, the most recent data from 2017 shows that the risk is down to about 1% in 1 month and about 2% in 1 year. And that's close to average for people in that age group. So the stroke risk over time with an improvement in technology and experience has gone down. But even so, a 1% risk of stroke is not 0%. And there are technologies now to help prevent stroke. And this is something that I use when I do these procedures whenever possible, which is about 90% of the time. This is called the Sentinel Cerebral Protection Device. This is the only approved cerebral protection device on the market right now. This is the aorta, and these are the blood vessels that go to the brain. The valve is down here off the screen, But this is a device that I put in immediately before we do the valve procedure and then take it out immediately after. And what you see here is two nets. Again, these are the blood vessels that go to the brain. These nets stay in position for the procedure. And if there's any debris that breaks loose, the nets will catch the debris. And after the procedure, after the valve has been replaced, we simply take out the nets. This catheter, this device, is put in through a small artery in the wrist. And just use a needle to get into that artery and put that device in there. Really easy. It adds maybe 8 minutes to the procedure, and it helps. In fact, there was a study looking at about 800 patients that had this transcatheter aortic valve replacement, and they looked at the rates of dying during the procedure or having a disabling stroke during the procedure. And you can see that people that had this device placed, this sentinel device placed during the procedure, had a significantly lower risk of a disabling stroke compared to those who didn't. We also know that stroke is directly related to death. So people that had stroke had a higher risk of dying. So if this sentinel protection device was used, the risk of dying during the procedure was significantly lower. So we would have liked to have seen a larger study validating these results, but this is about 800 patients and the results look very good. So I use this device for everybody. There's no way to predict who's going to have a stroke or who's not, so I use this device whenever possible. So I'm going to talk briefly about something called valve-in-valve therapy. We can use this transcatheter aortic valve device to replace old surgical valves. So sometimes people have open heart surgery and they have a valve that's implanted, and over time that valve can become worn out. So this is an example of a surgical valve that was placed probably about 12 or 15 years ago, and that valve over time developed calcium deposits, just like a normal your normal valve would. And that valve wasn't opening properly. So the surgeon had to go in and take out that valve and then sew in a new one. That means a second open heart surgery for that patient. Whenever somebody has to have a second open heart surgery, it's always a little trickier than the first open heart surgery because there's some scar tissue that's developed, and the person is probably about 10 to 15 to 20 years older. So the risks in the procedure are always more challenging for the second open heart surgery. So now what we can do is we can actually implant a new heart valve inside the failing valve that was implanted previously. This is an example of a procedure that was done here within the past year. So this is a special kind of ultrasound. It's called a transesophageal echocardiogram. An ultrasound is a procedure that shoots sound waves into the body and then collects the echoes that come back and turns that into a picture. So what you can see here is the heart, and this is one of the heart valves. This is an artificial valve that was placed, in this case, about 10 years before. This valve was used to replace a mitral valve. And this valve is failing. In fact, this valve has a very serious leak. What this is showing is that leak. So the ultrasound is now looking at blood flow, and you can see there's lots of blood flow, lots of swirling colors here. This is a bad leak. Blood is moving backwards across this valve when it shouldn't. So what we're doing here is we're advancing a new valve. This is the old valve right here. You can kind of see these three dots. That's our landmark. That's where the old valve is. And you can see here's a wire that the surgeon put in to put the chest back together. It's called a sternal wire. So advancing this valve, getting it into position. Whoops. And I went too far. And very carefully here, we're expanding this new heart valve. that's it. So hopefully you can see that there's no more of that swirling color moving backwards. The valve is in place, it's functioning properly, and we can use that ultrasound to get a good three-dimensional picture of the valve. And here we're looking straight down at the valve, and it's opening and closing perfectly. This thick ring that you see around here, this is the surgical valve that was implanted. The surgeon has to actually sew around that valve to keep the valve in place. And on the inside, you can see this inner ring. This is the valve that we just implanted. So there's always news when it comes to transcatheter aortic valve technologies. There's an ongoing trial right now looking at using a transcatheter aortic valve replacement for patients that have the condition but are at the lowest risk for complications for open heart surgery. In other words, the people that right now are healthy enough to have a very low risk for a complication during surgery, so they would go for an operation. The question is, would they do just as good if we implanted the valve in them? And that trial is ongoing. I can tell you the results are looking promising, but we'll get the study hopefully in the near future. There are new generation transcatheter valves coming out. One of the things that we can't treat right now is a leaking aortic valve. So sometimes people don't have a blocked valve, the leaflets are not thick, the leaflets instead are leaking. And there's not calcium that's built up. The leaflets are not hard. Our current technology only allows us to implant a valve inside an old valve that's become very thick, because we need that thickened valve to implant the new valve inside. So for some people, they just have a leaky valve, normal except it leaks. It's not hardened. So we don't have a good valve to treat these people other than open heart surgery. But those are coming. They're being tested right now. And then there are other valves in the heart, of course. The mitral valve is one of them. And we're coming, the companies are developing technologies to completely replace a mitral valve using a transcatheter approach rather than open heart surgery. That's a little bit down the road in the future, but that's being developed right now. So that was a very brief introduction. It's kind of a complex topic, but I hope it introduced you to transcatheter aortic valve replacement.
Thank you very much, Dr. Plank. Isn't it amazing what doctors can do these days? Very incredible information. We're going to go out of order right now because Dr. Sai was doing a surgery and he was going to be rushing over. I think he'll make it before 7. But in the meantime, let's maybe take some questions for Dr. Plank. Anybody have any questions?
What do you mean by leaky valve? What does he mean by leaky valve?
Leaky. So the question is, what do I mean by leaky valve? Yeah. So, let's see here. Yeah, so most of this talk was talking about how to replace a valve, an aortic valve that's become stiff and it doesn't open well. So that's what this technology can treat. When the leaflets of the valve become so thick, they're hard, we can implant a new valve inside there. A stiff valve doesn't open very well. It doesn't open all the way. Okay, that's the problem with a stiff valve. But a leaky valve might not be stiff at all. It might open just fine, but when it closes, it leaks. So blood moves the wrong direction. So when a valve closes, it's supposed to seal. So no blood is supposed to go backwards. But a leaky valve may close, but have a hole, and blood will move backwards. So that's what I mean by leak. It's kind of the opposite problem of a blocked valve or a stiff valve. Does that make sense? No.
I've got a question.
Yeah.
What would increase the risk of the calcific aortic valve stenosis.
Yeah.
Would taking calcium for osteoporosis or having symptoms of calcification and breast or
Yeah.
gallstones, those things, would that increase your risk?
That's a really good question. So what increases the risk of having calcific aortic valve stenosis? And we don't really know. So it turns out dietary calcium does not seem to affect aortic valve stenosis. So there's no diet that can prevent it. There's no diet that can treat it. There's no supplement that can cause it or prevent it. People that take calcium supplements for osteoporosis, there hasn't been a study that's proven that that's directly linked to a higher risk of aortic valve stenosis. So it's probably related to age and a lifetime of inflammation of the valve. And it always starts out with an imperfection in the valve, probably something microscopic, something you can't see, it's so small, but it's big enough where as blood is traveling through the valve, it causes the blood to have just a small amount of turbulence. The blood will swirl in that point. And that irritates the lining of the valve. And that causes inflammation in that little tiny point. And when the immune system reacts, our immune system will come to that point and it will do what it does. And then as it's leaving, it will lay down a little bit of calcium. And now you have a slightly more irregular surface than you had to begin with, and the process repeats itself. So that's one theory. But we don't know exactly what causes it. There's no medicine that can make it better or prevent it from progressing either. So no diet, no medication.
Any other questions? Oh, up front. Hang on.
How long does that stay in your heart? Does it last? How often do you have to replace it? You replace it later?
Yeah, I think that's a great question. So it's permanent. So the valve is permanent. But the question is, how long will it last? So a valve that's made out of metal, I don't know if you remember, but I mentioned when a surgeon opens up the chest and removes a bad valve and then sews in a new one, the surgeon can put in a metal valve or a valve made out of animal tissue. A metal valve will last forever. But somebody that gets a metal valve, the downside is somebody that gets a metal valve needs to be on a strong blood thinner forever to help prevent a blood clot from forming on that valve. So a metal valve lasts forever. But a valve that's made out of animal tissue from a cow or from a pig, there's always a limitation as to how long that can last. We know that the type of valve that a surgeon will put in typically lasts between 12 and 15 years before those leaflets start to have a problem. And that's based on decades worth of data, because the surgeons have been doing that procedure for decades. Now, the transcatheter aortic valve has not been around for decades, but it's made, the actual valve part, the leaflets, are made of the same exact material as the valve that a surgeon would put in. We expect that it should last as long as a valve that a surgeon would put in, between 12 and 15 years before having a problem, but we don't have the long-term data to back that up. We do have studies showing that it lasts as long as a surgically implanted valve, up to 8 years. But longer-term data we're waiting on.
Next question.
So for people in their 70s or 80s, what would be a test that, early detection of this problem, even if they don't have any symptoms, or is it, they have to have symptoms before you can do a test, or
Yeah.
is there an easy way to tell if you're in your 70s and 80s?
Yeah, that's a good question. Should people in their 70s or 80s, which is the population that tends to be affected by this the most, should those people be screened for the condition with a test? By the way, the test to really really pin down whether or not you have this would be a test called an echocardiogram. That's an ultrasound of the heart that can be done in a clinic or a cardiology office. But it's not recommended to screen everybody in that age group for this condition. The majority of people won't have this condition, even people in their 80s and 90s. About 15 to 20% will when you're in your 80s or 90s, but the majority won't. So the best way to screen for this is really to see your primary care doctor regularly. And your primary care doctor is going to, hopefully, is going to be listening to your heart every time that they see you. And if a murmur is picked up, that would be one reason to get the test. The other reason would be, even if they don't hear a murmur, if you have symptoms that are typical or classic for the condition, your doctor may send you for that echocardiogram test. So seeing your primary care doctor regularly is the best way to get screened for this condition.
The question is that, is this a hereditary condition, for one? And then secondly, is there an age bracket to perform this procedure? If one is 90, would you perform it?
Yeah, those are good questions. So the first question, is it hereditary? So the most common type of aortic valve stenosis is the calcific aortic valve stenosis, where the calcium builds up on an otherwise normal valve. And it turns out that that is not hereditary. Rheumatic valve disease, which is from rheumatic fever, is not hereditary. Although you will often see that in families because oftentimes multiple family members, brothers or sisters, for example, may have had the condition when they were growing up together. Of course, radiation therapy to the chest would not be transmitted in the family. Bicuspid aortic valve disease, so the birth defect one, where you're born with a valve that's not normal, perhaps having 2 leaflets instead of 3 leaflets, that actually can be transmitted in families. So if you have that condition, you would want your kids to get checked for it. So that's the birth defect type. Oh, sorry, and there was one other, what was the other part of your question? Oh, yeah. Yeah, so is there an age cutoff? Turns out there's not. So I think the oldest person I've performed this on is 100. It's been done on, I think, 106, I think is the oldest. And there's no absolute age cutoff. Everybody is evaluated individually. The most important thing is not the age, in my opinion. The most important thing is how strong somebody is, how active they are. Because really there are 2 reasons that we do this. The first reason is to help people live longer, and the second reason is to help people feel better. If somebody's in their late 90s or early 100s, I can tell you I've never met somebody who's 100 that is worried about living longer. They want to feel good for the rest of their lives, whether that's 20 years or whether that's 6 years. They want to feel better. So we really want to make sure that that person is in a condition where if we put them through that procedure, they're going to be able to do activities and feel good. So we really have to look at everybody individually. It's not about how old they are, it's about what condition they're in and what their potential for improvement is.
I've been told that I have an intermittent murmur. So what is an intermittent murmur, and when does the murmur become serious?
So a murmur is just the sound that blood makes as it's going through an abnormal valve. That could be because of a blockage in a valve, like aortic valve stenosis, where the leaflets are getting stiff. It could be because of a leak. An intermittent murmur is a murmur that sometimes it's easy to hear and sometimes it's not. And sometimes that means that it comes and goes. Other times it means that whoever's listening to your heart just can't hear it all the time. maybe they're like me, have bad hearing, which I have. But if you have a murmur, it would probably be a good idea to talk to your doctor about that and determine whether or not an ultrasound or an echocardiogram would be a good step, because that would really tell us why you have that murmur. The vast majority of murmurs are not serious problems. Murmurs are very, very common. So just talk to your doctor about it, and they would be able to tell you where they're hearing the murmur, what they suspect it is, and whether or not an echocardiogram would be in order. Yeah. By the way, kids oftentimes have murmurs, and they outgrow them. So we call those flow murmurs. Very, very common in children. So if you happen to have a kid or a grandkid and they've been told they have a murmur, that's pretty common. Just make sure they talk to their pediatrician about it, but it's probably nothing serious in most instances.
Sorry, just a question about recovery. So after the procedure, you're saying 1, maybe 2 days in the hospital.
Yeah.
What are the restrictions on the patient and the expectations on the patient after they're released?
Yep. So more than half of our patients go home the next day. And the same day the valve is put in, we have them in their bed for about 4 hours, and then we have them get up and walk around the unit. So they go home the next day on average. Sometimes they stay an extra day. As far as restrictions go, there's really no restriction for the heart. The valve works instantly. The heart doesn't need to recover. It's the access point. It's where we put that catheter. So in most cases, the catheter is put into the artery in the groin, and we have to allow that to heal up. Usually a couple of stitches are put in using a special tool that we use during the procedure, but still that point in the artery in the groin has to heal up. So we usually tell people, we don't want you to lift anything heavy for about a week. So just kind of take it easy. You can walk around, you can do normal activities at home, but I don't want you lifting heavy bags of groceries or running marathons or anything like that. So that's for about a week. That's what the restriction would be. Also, patients that get this treatment have to be on aspirin. Aspirin is recommended lifelong. And for, on average, about 6 months, we like them to be on another medicine, typically something called Plavix, which is similar to aspirin. It's a mild blood thinner. So if people have bleeding concerns or bleeding problems, we have to talk about that beforehand.
Any other questions? Oh, my side's doing so well.
So a quick question regarding the procedures that you mentioned. Do you generally use a contrast dye? And the reason I ask that is for people who have concerns about if they have chronic kidney disease and may be on the brink of needing dialysis.
Yeah, that's a very important question. We typically have to use some contrast. Contrast dye is a liquid that's injected into the arteries. It allows us to see what we're doing. So we can see exactly where the valve is in space, or when we're positioning the new valve, the implantable valve, we have to be sure we're precisely in the right spot in the old valve. And to do that, we have to give some contrast. Oftentimes, we have to give contrast as well to look at the arteries in the groin, in the leg, to make sure that there's no bleeding and to make sure we're in the right spot. On average, we use a very small amount of contrast, but typically we have to. So if somebody has bad kidneys or chronic kidney disease to begin with, we have to be very careful about using just enough contrast but not too much. There's a weight-based formula to determine how much is too much for somebody based on their weight and their kidney function and also their age. So we make that calculation beforehand. And also we can give people IV fluid both before and after the procedure to help flush away the contrast and protect the kidneys during that procedure. So there are ways we can prevent kidney damage from the contrast dye that we have to use, but that is a risk. And if somebody's already on the brink of needing dialysis, then that's one of the major risks for that person, is the possibility of needing dialysis afterwards.
would you talk to us a little more about leaky valves and what happens, and do they last forever? Do they get worse? Do they shut up? I'd like to know more about them.
Yeah, so the question is about leaky valves and what happens to them. So leaky valves, again, when the valve opens, so when the heart's pumping, squeezing blood, it squeezes blood through a valve. So the valve has to open up to allow the blood to move forward. And then between heartbeats, when the heart's relaxing and getting ready for the next heartbeat, the valve is supposed to close and prevent blood from moving backwards, back into the heart. So a leaky valve doesn't close properly. So there's blood rushing backwards. That's what a leak is. So what do we do about that, or what happens? So if there is a leaky valve, it depends on, first of all, it depends on which valve. Some valves are notoriously leaky. So there are 4 valves in the heart. Oftentimes, 2 of them will have at least some degree of a leak, hopefully very mild. But most people will have some level of a leak in at least one of their heart valves. But when the leak is in the aortic valve, for example, that's not normal. And if the aortic valve leak is very mild, hopefully it will stay mild, but usually it will gradually get worse over time. So if somebody has a leak that's in a place that's not where I would expect it to be, what I would recommend is that that person have an echocardiogram every 1 to 2 years, depending on where the leak is and how bad it is. And that would be to follow that to determine whether or not it's getting worse. If the leak becomes worse, then we have to figure out how to deal with it. Depending on where the leak is and which valve it's affecting, there are different options. But it just depends. So yeah, a leaky valve can cause problems if it gets bad enough. Oftentimes it will get gradually worse over time, and it depends on which valve is affected.
Any other questions? Susan's coming down on your right.
Why does the transcathering aortic valve replacement has to go through the leg? Such as for the coronary artery procedure, they go through their arms artery, but then I've seen that from your PowerPoint, it was going through the crouch area vein vessels.
Yeah.
Why do we have to go through the crouch area rather than go through the arms?
Yeah, that's a good question. I look forward to the day we can do it through the arm. So back in the old days, like 2005, almost all coronary procedures were done through the groin as well, and certainly before that. So the artery in the groin is a lot bigger than the artery in the wrist. The wrist artery, also called the radial artery, is quite small. Over time, the catheters and equipment used for coronary procedures, whether it's an angiogram or putting a stent in a coronary artery, all of that has gotten smaller over time. So the diameter of one of those tubes is 1.5 millimeters or 2 millimeters, very, very small. But the diameter for the tube we have to put in to deliver a heart valve is about 5.5 millimeters. So we need a much bigger vessel. So that's the reason we have to go in through the groin. Yeah.
So for the patients who have already had the valve-in-valve procedure, and it comes to like 15 years down the road and they need another one, what is the procedure that you do for that? Is there a limitation on the valve-in-valve replacements, or do you just have to then go to doing actual surgical methods about it?
Yeah, that's a good question. So what happens when you've already done valve-in-valve and then the valve-in-valve has a problem? So sometimes you can do a valve-in-valve-in-valve, but not always. So the limitation there is space, every time you put a new valve inside of a old valve, it narrows the opening a little bit. So oftentimes we're limited in that case. For example, the valve-in-valve procedure I showed you went very well, but I don't think there would be room to put a third valve in there if that ever failed. Usually, once it gets to the point where the first valve failed, and we do a valve-in-valve, the person tends to be older because they've gotten, maybe 12 to 15 years out of their older valve, and now maybe they're in their 80s or so, and we hope that the valve we implant will outlive them. But if that valve fails, then yes, we'd have to either consider a valve-in-valve-in-valve or surgery, but probably if they had a valve-in-valve previously, surgery isn't an option for that person based on their age and other medical problems. So it's something we would have to very carefully look at. If there's room in there, we could do another valve-in-valve though. But we would have to look at that with a very special imaging procedure beforehand. By the way, it's interesting, the new generation of surgically implanted valves, if you look at a valve that a surgeon puts in the heart, there's a ring, and then on the inside you have the leaflets that open and close. And that ring is pretty solid, and the surgeon will implant that and sew it in. The new generation, some of the new generation valves, in fact, the company that makes the transcatheter aortic valve that we use, their surgical valves that they make, they now put in these creases that if we ever have to put a valve-in-valve, it will actually expand the surgically implanted valve to allow more room for the next valve. So they're being designed with that in mind.
Is heart palpitation the same as murmur?
Is heart palpitation the same as murmur?
No. So the question is, are heart palpitations the same as murmur? Heart palpitations is a sensation that someone may have if their heart is beating irregularly. So the heart's supposed to beat like clockwork, but sometimes people notice that their heart is beating not like clockwork, it's beating erratically. Maybe it's going a little too fast, or maybe it's skipping beats, and that will get your attention for a lot of people. That sensation is called palpitations. A heart murmur is a sound that blood makes when it goes through an abnormal valve. Turns out, though, that people that have an abnormal valve will oftentimes have palpitations because that abnormal valve is putting stress on the heart, which leads to irregular heartbeats, or the heart not beating like clockwork, and then they feel palpitations. So usually they go hand in hand.
When you do exercises, should you slow it down after you do something like that, or can you just walk, or after surgery, what kind of exercises are you able to do?
After the valve has been replaced? Yeah. So after the valve has been replaced, you have no more valve problem. So you have no more limitation. You can do you want to talk to your heart doctor, because you may have other heart problems, but assuming you don't, there's really no restriction as far as what kind of exercise you can do. The major thing is that you wait long enough so that the artery in your groin heals up, because you don't want that to bleed. So you want to give it at least a week before you start doing exercise. But I certainly encourage the people that have this procedure to get out there and exercise afterwards, because that's the whole reason we did it, so that you can get out there and move again.
Any other questions? Well, we certainly want to thank Dr. Plank for being such a trooper to speak for the entire lecture today. Thank you.
I don't see
Yeah,
Dr.
so, I'm sorry?
I don't see Dr. Sai.
Yeah, Dr. Sai, as we mentioned earlier, was called into an emergency surgery, and so, that happens. And so he had to go take care of a patient. We do want to thank Dr. Plank again for speaking for the entire hour and a half. Thank you so very much, and such important information and fascinating information. The 100-year-old patient, that was amazing. Do want to thank from Queen's Heart, the folks who are out there providing information, Mikiala, Pearl, Brittany, and Joyce. Also Kim and Dwight from the American Heart Association for being here. Also Val Milstein, who is our special guest providing American Sign Language interpretation. Also our Queen's volunteers, Susan and James. Thank you all so much. So our next Queen Speaking of Health lecture will be on colorectal cancer. March is Colorectal Cancer Awareness Month. Learn what it is, what the symptoms are, and what puts you at risk. Is there a difference between colon cancer and colorectal cancer? How common is colon cancer? You'll also find out about different polyps, screenings, and what tests are not recommended to screen out for colon cancer. Get tips on preparing for a colonoscopy, and learn what you can do to prevent colon cancer. Featuring Dr. Tracy Murakami, who is a gastroenterologist at the Queens Medical Center. This is on Wednesday, March 27th, 6 o'clock to 7 o'clock p.m., free, here at the Queens Medical Center, Punch Bowl Queens Conference Center. So you can register online at www.queens.org, click on classes and events, or call the Queens referral line at 691-7117. So thank you all for attending the Queens Medical Center Speaking of Health lecture. Don't forget to get your parking validated in the lobby, and have a wonderful evening.